Won't have an empty seat now.
Oh, yeah,
Good morning. I'm going to call the meeting to order. I have the time as 10:02.
wow.
Our first item of business this morning is to approve some resolutions that we have to honor previous board members, Dr. Bruce Vladeck and Dr. Marlon Brewer, who served on this board for a number of years and continued beyond their appointments. And I will read these resolutions for approval by the board. The first one is for Dr. Vladeck, and it reads, whereas Bruce C. Vladeck, Ph.D., has been a member of the Board of Health since 2002, and whereas Dr. Vladeck represents the very best in the health profession, having spent his professional career working in healthcare policy, and whereas as an expression of its deep appreciation of Dr. Vladeck's service and extraordinary commitment to improving the health of the residents of our city, it is therefore hereby resolved that the Board of Health and all of its members congratulate Bruce C. Vladeck on his retirement and extend to him their heartfelt gratitude for his dedicated service to the City of New York as a member of the Board of Health. So may I have a motion to approve this resolution? And a second? Second. All in favor? Aye. Any nays? So it passes unanimously. Thank you. And for Dr. Marlon Brewer, I will also read this resolution. Whereas Dr. Marlon Brewer has been a member of the Board of Health since 2006, and whereas Dr. Brewer represents the very best in the healthcare profession, having spent his professional career working in the field of ambulatory care, and whereas an expression of its deep appreciation of for Dr. Brewer's service and extraordinary commitment to improving the health of the residents of our city, it is therefore hereby resolved that the Board of Health and all of its members congratulate Marlon E. Brewer on his retirement and extend to him their heartfelt gratitude for his dedicated service to the City of New York as a member of the Board of Health. May I have a motion to approve this resolution? And seconded, and all in favor? Aye. Any opposed? It passes unanimously, and we will see to it that both Dr. Vladeck and Dr. Brewer receive these resolutions. They also have received a letter of appreciation from our Mayor, Bill de Blasio. We also have today some new members of the board to introduce, and I would like to take a moment of your time to say a little bit about these distinguished new members, offer you some very brief biographies. I'm sure it won't be difficult for you to find much more about them. Dr. Rosa Gill, who's seated here to my right, to your left. Dr. Gill has had a distinguished career in the fields of health, mental health, social services, and academia. She is currently the president and CEO of Communilife, Inc., a multi-service not-for-profit organization that she founded. It assists New Yorkers to achieve self-sufficiency and a better life in the community. She served in various city government roles with the mayor's office, HHC, HRA. In addition, she's held executive-level positions at Woodhull Medical Center and Metropolitan Hospital. Dr. Gill is also the former University Dean for Health Sciences at the City University of New York. I will now introduce Karen Redlener, who is seated here to my left. Karen Redlener has had a 35-year career dedicated to improving access to health care for some of the nation's most disadvantaged children. Ms. Redlener is a founding member of the board of the Children's Health Fund and the executive director of the organization. Ms. Redlener has been the director of the New York Children's Health Project, a program serving homeless children and families since its inception in 1987. In addition, Ms. Redlener served at the South Bronx Health Center for Children and Families, a neighborhood-based health center serving a highly underserved, economically distressed community. And finally, Dr. Ram Raju, who will be known to many of you as the President and Chief Executive Officer of the New York City Health and Hospitals Corporation, the largest municipal healthcare system in the nation. Prior to accepting this role, Dr. Raju was the Chief Executive Officer for the Cook County Health and Hospital System in Chicago, Illinois, the third largest public health system in the country. And Dr. Raju began his medical career at Lutheran Medical Center in Brooklyn, went on to serve as the Chief Operating Officer and Medical Director at HHC's Coney Island Hospital, and in 2006 he went on to be the HHC's Chief Medical Officer, the Corporate Chief Operating Officer, and the Executive Vice President. I'm delighted to welcome these new members to the board who bring a breadth of experience and expertise to our deliberations. The next item of business is to approve the minutes from the previous meeting. We don't have Dr. Foreman with us today. He's on a scheduled vacation. He is generally our very careful reviewer of the minutes. I've reviewed them. Do I have any changes to the minutes?
Yes, well, in Dr. Foreman's absence, I feel compelled to carefully read. But I do have a couple of minor errors. I could just give them to the stenographer if I don't think there's anything substantive that needs to be read into the minutes.
That would be fine. Are there any other comments on the minutes? So for
I
those,
said one comment.
yes.
I said that there were several minor comments also, but maybe one that is substantive. On page 11, on the second paragraph, it reads, "So the requirement for securing and monitoring remains for all entrances and exits, and so changes to the physical facilities present a genuine hardship." I think that might be missing the word "if." I think it's suggesting if changes to the physical facilities present a genuine hardship. I think it's suggesting that if those changes need to be made, they will be heard by the board.
Okay. All right, so noted. Okay. And thank you. Without amendment to the minutes, then may I have a motion to approve?
So moved.
All in favor?
Aye.
Any opposed? Any abstentions? So the motions pass. I will now move on to reorganize the agenda a little bit, and I'm going to talk about the proposal to repeal the rules governing consent for certain circumcision practices. I'm going to begin with a request to post for public comment a proposal under Article 181 of the Health Code. I'm asking the board to consider repealing the requirement that ritual circumcisers, also known as mohalim, obtain parental consent before the performance of direct oral suction of the circumcision wound as part of the circumcision ritual of infant baby boys. In the Orthodox Jewish community, direct oral suction is known as Matitzah B'Peh. As background, as you know, in 2012, the board approved a requirement that written consent be obtained from families before direct oral suction could be performed as part of a circumcision ritual. In adopting this rule, the board's intent was educational, and the board acted out of concern for infant health. Neonatal herpes was made a reportable disease in 2006, and since that time through 2014, there have been 16 cases of herpes as a consequence of direct oral suction. 2 infants died, and 2 suffered serious neurological consequences of herpes infection. So the board sought to ensure that parents were educated about the risk of herpes transmission to the baby as a result of this practice. Since the consent requirement was adopted through 2014, there have been 6 cases of herpes simplex 1 infection reported in infants following direct oral section. In 2 of the 6 cases, the moyo, or the ritual circumciser, who was associated with the case, was identified in the course of the department's case investigation. A signed consent form was provided in one of these 2 cases. The Orthodox Jewish community views the requirement as an intrusion on an ancient and sacred ritual through which a baby boy is welcomed into their community, particularly as the rule requires that ritual circumcisers, the mohilim, collect and maintain the written parental consents using language prescribed by the health department. As a consequence, this well-meaning rule has had a polarizing effect, with the community coming together in widespread opposition to the consent requirement. An effort that was educational in its intent has now encountered enduring community hostility. And because the community feels so strongly, it shouldn't be surprising that implementing the regulation has been challenging. In retrospect, the current requirement has mandated that education about medical risks of direct oral suction be given at the wrong time, in the wrong place, and by the wrong person. In my 30 years of public health experience in academic literature and common sense, all would suggest that creating anger and hostility is contrary to any educational effort. Cultural sensitivity is central to how we work. We need a new approach to educating Orthodox Jewish parents about the risk of herpes simplex virus type 1 transmission from the moyo to a baby boy during direct oral suction. Medical information is best conveyed in a secular healthcare setting where medical professionals can provide information and answer questions well before the circumcision is performed. And it's better to get this information before or near the time of birth when there's a good amount of time to plan for the circumcision ritual or the bris, which takes place on the 8th day of life. So I believe that we have, I want to show you, so I believe that this approach that we are proposing will be more effective because there's a greater chance that the community that we're trying to educate will be more receptive to our message. And I wanted to share with you a copy of our brochure that we have developed. It's called Making a Safe Bris for Your Baby. I wanted to show it in contrast to the old version. And nobody will be able to read it from there. This is what the old one looked like. And this is what, I don't know, it doesn't match any idea that I'm aware of about ease of conveying information. We have developed a much better, in my opinion, brochure, one that contains all the information that a parent needs for the board members. I'm sure that each of you has a copy. We will be distributing this to hospitals, to OBGYN and pediatric practices that serve the Orthodox community. And we've already distributed this brochure to Maimonides Hospital, and I understand that it has been well received. This is a tight-knit, close-knit community, and I have received no negative feedback about the presence of the brochure. So we therefore ask that the board consider repealing the requirement that consent be obtained by parents by direct oral suction when it is performed as part of a ritual circumcision. And I am happy to begin a discussion with the board about this request.
You want to go first? You want me to go first?
Do I have hands up? Sure.
I want to thank you, Dr. Bassett, for that. I can understand how this proposal might have been met with resistance by the community, and you've suggested that it might be at the wrong time, the wrong place, and by the wrong persons. And it is important to readjust our public health efforts so that it is met with, I guess, collaboration with our partners in the community. I had a question about the alternate proposal that you had just mentioned to us. Are you proposing that this is a voluntary plan to distribute these brochures? Or is there a plan to have another proposal come to this board in the future with a required educational effort at the time of delivery in the communities that are affected? Is that what you're proposing? I just
Well,
wanted to be clear.
No, what I'm proposing is a voluntary effort. As you're aware, Dr. Gowda, we do not regulate hospitals. But we have had conversations with hospitals, and we have received their assurances that they will distribute this pamphlet. The pamphlet has been well received by the healthcare providers. Everybody thinks it's a much better pamphlet. It will be made available not only in English as the version that you're looking at, but of course also in Yiddish. But we do not regulate hospitals, and we could not make such a requirement. Of course, lots of educational material is made available to women when they are seeking prenatal care or care for their other children, or when they come in to deliver their baby.
So I would say that Borough Park in Brooklyn is probably the epicenter of sort of the origin of the most cases that the health department has on record. And I have been working on this issue since well before the last Board of Health vote. And babies from the community obviously come to us. It's very stressful for all people. And when this last program was put into effect, promulgated by the Board of Health, there was a real sort of step up in animosity against the city, against the health department, about the intrusiveness of a brochure like the one Dr. Bassett held up. And some of us who work there had actually been concerned about it, but we've watched it faithfully over the last few years. And I have to say that the issue, and we have been very active in distributing these brochures. I will say amidst a lot of negative reaction, but undaunted, we have forged ahead to follow the rules here. There appears to be no relationship, actually, between the distribution of the previous forms and the incidence of these children coming in with cases of herpes. It's been sort of a steady state, I think one or two a year. By no means happens every day, but the rate of incidence has had nothing whatsoever apparently to do with handing out those brochures. And I have to say we've all been troubled at Maimonides about this issue. So as to the matter of public education, we really have been heartened, I think, by the fact that people are actually talking about this without throwing eggs and tomatoes at each other. You don't have to put that in the minutes. And that the mayor and the mayor's office and the health commissioner have been able to have conversations about what seems to make more sense. Now, I'm sorry to go on and on, but I just want to give the flavor of this. I want you all to understand that this practice is, I don't know, centuries old, and it probably is the only, that I can think of, the only medical procedure that goes on without a written consent, but it's very unique. And it's my opinion that education is the only way to go on this. I mean, when I saw the brochure, the first thing I did was call Dr. Bassett and say, okay, let's put this in Yiddish. And we have to figure out if that's the only language. We have given them to doctors already, and there's some doctors' practices where they will be better received than others. We know that. But we have been distributing them to women who schedule themselves for an inpatient procedure. So that's usually 6 weeks to a month, 2 months before delivery, and that seems to have gone well. I've shared the brochure with all of the nurses who work in our obstetrics unit and our birthing center. Maimonides is the largest birthing center in the entire state of New York. We last year delivered 8,500 babies, and I don't know, about 40% of them, give or take, were Orthodox Jewish, so their registration said. Then I don't know what percent were boys, but they weren't all boys. But so we have shared them with everybody so far since I got the brochures on Friday. I have to say that if you can't talk to someone, you can't have a conversation about this. And we have been unable to talk to anybody about this. People just simply refuse to talk about it. Since the other policy was put into effect. Now, one last word about sort of community engagement that we talked about, that you just spoke about. So before the last Board of Health vote on this issue several years ago, Tom will remember, I was either called or visited by, 10 or 15 different leaders of the ultra-Orthodox or Hasidic community with great consternation, importuning me to decry this approach. And I have received not one phone call. And I don't believe it's because people think they're getting away with something. I think the sense I have in talking to community leaders is that this is a better way to go, and that in some cases it might really have an impact. So it is in its own way sort of informed consent prior to the bris. So I'm very positive about taking this step today.
Thank you, Ms. Breyer. I would like to entertain other comments and questions from the board.
I'm very happy to be here at my first meeting, and I have read a lot about this issue, though I am new to this board and conversation. I just have a few questions about the next step, or what happens if the current ruling, the current law is repealed, current regulation is repealed, and to ensure that this information gets to people at the right time, as you're saying. And I heard you say that it will be distributed through hospitals, and I just want to also recommend that the community-based health providers would also, if we could be proactive about sending out this information to put it in their hands during the prenatal period, that it's possible that some families do access care in a private practice or a community health center or other facilities that are not affiliated with hospitals as well.
So to the first part of your question, what the board is being asked to consider today is whether or not this request to repeal should be posted for public comment. So this is not a decision today to repeal the rule that required ritual circumcises to obtain informed consent and maintain a written record of that consent from parents before performing this part of the circumcision ritual. So today we're just considering whether it should go forward for public comment. in which all stakeholders can have a say. You are absolutely right that the information needs to be made available more broadly than in hospitals. And also, it should be provided in obstetricians' offices, private offices. We, working with the community, have identified practices that serve this community, and the receiving hospitals where deliveries take place are also familiar with these practices, so that this brochure would be made available to them. It's also, I think, important to make it available in pediatric practices. People have more than one child. A person coming for a pediatric practice may have another child, and this information will be valuable to them. I think my point about the healthcare setting is that that is a good setting in which to discuss medical risk. It's a secular setting. It's also in advance of the ritual circumcision, so that people have good time, the right people to ask questions about the medical risk. So your point's well taken, that it should be more broadly distributed. That would be our plan.
Let me just, maybe I wasn't clear enough. So we have a network of health centers and a network of doctors, and we are going to be pediatricians as well as the obstetricians. As I said before though, there are some groups of doctors here and there in Southwest Brooklyn who deliver their babies here, but who don't work for us, and therefore it is really, we can't force them to take these brochures, but the idea is not to wait till the very last moment.
So anybody who, in the medical community, who wants these, will make them available. Midwives, everyone, and the pamphlet itself offers 311 as a way into the department to get more information. So if somebody wanted to talk to somebody other than their healthcare provider, they could reach the department through 311. Dr. Klitzman and then Dr. Richardson.
Thank you. So as a board member who was here and voted on the earlier provision, I do feel strongly that we meant well, that we acted upon the best available information at the time. But I also deeply appreciate Commissioner Bassett's remarks and Pam Breyer's remarks, which remind us that in order to be effective as public health professionals, we have many arenas to pay attention to, and I think this example just reminds us how important cultural sensitivity is, and also engaging stakeholders. So I'm very proud to sit with my fellow board members here today in engaging in the next step on this important issue, and I strongly support approving the hearing, where we will have an opportunity to hear from all of the stakeholders and affected individuals and take their comments and concerns under consideration. And I also want to support all the efforts that the department has made so far to engage with the community and to develop materials that are reflective both of public health standards as well as reaching to the affected community. And I think I'll just close with a personal note. As a Jewish mother who has a son who did have a bris, I would say that at the time of the bris, with a house full of people and a caterer, doing an informed consent at that moment, I guess in retrospect, probably wasn't the best time, and certainly a more preventive approach, I think, would be more effective. Thank you.
Dr. Richardson.
Thank you. So I also was on the board at the time the previous rule was passed, and I do have a few questions. I remember quite clearly the information that was provided to the board at that time about the dangers of neonatal herpes, about the medical consequences that some of the infants had suffered, including death and serious neurologic disability. I also, because this was not a topic that I knew a lot about, I'm a mother but not a Jewish mother, and I had 2 daughters, so Bris never really is not part of my lived experience. But we were told that this was not a practice that was universally supported by all Moila who work within this community, that there are other acceptable ways of performing the ritual, that this is, so there's some heterogeneity about the extent to which this is a required part of the ritual. It's just, we haven't heard that today, we were told that at the time, and so I want that to be part of the record as to how we, and I see everyone agrees to that. We also were told about complaints that had come to the department by parents who were perhaps not part of the Orthodox community, but who had engaged Moila who were, and their surprise and dismay when this practice occurred during the bris, and that they had had no idea that this was part of the ritual and so on. And so I think it is true that it was very much our intent to at least make sure that everyone was aware that this procedure might be performed as part of this ritual, and that there were risks to this procedure. I support the idea of opening this up for public comment, because I think the department and the mayor have heard very clearly, and it sounds like Pam Breyer also from a community that feels very strongly about the rule and this practice. But I'm interested to see what other segments of the community we hear from, because I think we consider the interests of a large number of stakeholders in this when we made the previous rule. But I do support the idea of getting comment on this. I think we certainly need to reopen this conversation at least and hear what people have to say. The other thing I just want to ask, to be clear, so you made mention of the feeling of intrusiveness of this rule. To what extent, outside the investigation of actual cases of herpes, has the department attempted to either enforce or do surveillance on this practice of obtaining consent?
This has been effectively a complaint-driven process, one that is triggered by the identification of a case of neonatal herpes. So there was, as the board discussed, and I've read the minutes, although I wasn't here at the previous meetings, there was never any intent to regulate the procedure. The intent was to ensure that parents were educated so that they could make an informed choice. So when we learn about cases, and only through their identification, this isn't the only thing. Smoking indoors, for example, is all complaint-driven, and so that was how this worked. I think that the idea of intrusiveness was the notion that a person whose world was the world of religious practice and a practitioner of an ancient and highly really valued sacred ritual was being asked to convey medical risks. That was where the sense that this was intrusive arose, as I understand it from conversations with the community. Are there any other comments or questions?
So not through any action of the departments, but simply the existence of the rule itself.
That is correct. All right, if there are no further comments, then I'll ask for a motion to approve. And a second? Seconded, and all in favor, we'll have to go, we want to,
You can do show hands now.
we can do a show of hands, all in favor. So it's unanimous. Thank you. We'll move on now to the next proposed resolution to repeal and reenact section 8150 of Article 81 of the food preparation and food establishments of the New York City Health Code. We have a presentation on this. This action is requested of the board to begin the process of bringing the city's rule on calorie posting into alignment with the federal regulations that will go into effect on December 1st. Please, can you identify yourselves for the record?
Hi. Hello? Yes. I'm Dr. Sonia Angel. I'm the Deputy Commissioner overseeing the Division of Prevention and Primary Care.
And I'm Corinne Schiff, Director of Special Projects in the Environmental Health Division.
All right, so thank you very much. It's a great, we appreciate the opportunity to be here today in light of the new federal calorie labeling regulations from the Food and Drug Administration today. As mentioned, we're proposing that the board repeal and reenact Article 1850 in order to achieve consistency with the federal rule. Because the newly issued federal regulation was modeled on New York City's calorie labeling rule, I'd like to take a moment to revisit the history of calorie labeling locally. As you know, in 2006, New York City's Board of Health adopted a calorie labeling rule, making New York City the first municipality in the nation to require chain food service establishments to post calorie information on menus and menu boards. In 2007, the New York State Restaurant Association filed its first lawsuit against the rule, alleging both federal preemption by the Nutrition Labeling and Education Act and violation of its members' free speech rights. While striking down the specific way the 2006 rule was drafted, the court generally upheld the right of the Board of Health to mandate disclosure of nutrition information for restaurant food. In 2008, the board adopted a revised calorie labeling rule, and the New York State Restaurant Association filed a second lawsuit. The federal court sided with New York City, and restaurants started posting calorie information in March of 2008 while appeals were underway. In 2009, the U.S. Court of Appeals Second Court ultimately upheld the calorie labeling rule. This set an exciting precedent that would be leveraged repeatedly in other municipalities battling obesity and other diet-related diseases. Since then, several counties in New York State, including Albany and Westchester, as well as numerous localities and states, including Seattle, Philadelphia, Massachusetts, California, and Oregon, amongst others, have introduced calorie labeling regulations. The momentum achieved in New York City and elsewhere resulted in the incorporation of calorie labeling requirements into the 2010 Affordable Care Act. In 2014, the Food and Drug Administration issued the federal calorie labeling regulations. These are the regulations that we are considering today. The federal regulations go into effect on December 1st, 2015. Exposure to calorie labeling increases consumer awareness. This plays a critical role in educating consumers about calorie content and in facilitating healthy choices. Since the enforcement began in 2008, more than 1 million New Yorkers see calorie labels every day in restaurants. In addition, there's evidence that calorie labeling has had a positive impact in terms of consumer behavior. Studies show that individuals who see and use calorie information purchase fewer calories than those who do not. In one study conducted by the health department, patrons who reported using calorie information purchased more than 100 fewer calories than those who did not. And we know that a majority of New Yorkers find calorie labeling useful. This slide illustrates the results of a 2011 poll of New Yorkers. It shows that nearly 80% of respondents said that they think the calorie labeling information in fast food restaurants is useful. Although New York City's calorie labeling rule was challenged initially, over time restaurants have demonstrated the ability to comply to the rule. In fact, the National Restaurant Association supported federal regulations on calorie labeling. The introduction of a federal calorie labeling regulation is an exciting development and serves as a reminder for us to recognize and honor the important achievement of the board in this area. My colleague Corinne Schiff will now present on the specifics of the amendments that we're proposing today.
Thank you. Good morning. Again, I'm Corinne Schiff, and I'm the Director of Special Projects in the Environmental Health Division. And I'm going to review the changes that we are proposing to the health code in light of the federal regulation promulgated by the FDA. And I want to start by providing an overview of the issue before the board today. The health code must be made consistent with the federal regulation in order to remain enforceable. And so the amendments that we're proposing are designed to align the health code with the federal regulation. There are some areas where the health code can differ, and I'm going to highlight those first. And you'll see as we go along that the adjustments that need to be made are largely in the details, and the core New York City requirements remain unchanged. So first, who is required to post calorie information? With respect to restaurants in New York City, we're proposing that no change be made to the current coverage in the health code. Currently, restaurants that are parts of chains with 15 or more locations nationwide, including mobile food vendors, have to post calories. Here the federal regulation is a little bit different. The definition of a chain is those that are part of, that have 20 or more locations that are only fixed site. But the FDA has said that localities can be more protective, and so we're recommending that we maintain the current coverage in the health code. And that's because at this point, this is a long-standing New York City rule. New Yorkers, as you've heard, expect and rely on this information. And we see excellent compliance in the industry, and so we think that maintaining the status quo is really not burdensome. The FDA regulation also applies to chain retail food establishments, and these are supermarkets, convenience stores, other food retailers in their sale of prepared restaurant-type food. Again, the federal definition of a chain is 20 or more locations nationwide. And we're proposing to the board today that calorie labeling be extended to these establishments, maintaining a consistent definition of a chain. We're also asking that the board authorize the Department of Consumer Affairs to enforce. DCA enforces consumer regulations in these stores, and so there's some efficiencies to be gained. Next, moving into sort of the substance of the posting requirements, and here's where there's really not much flexibility. The health code has to be aligned with the federal requirements. Most different under the federal rule is a requirement that establishments provide nutritional statements and information. Every menu and menu board has to have 2 statements. You'll see exactly there what has to be written. 2,000 calories a day is used for general nutrition advice, but calorie needs vary, and that additional nutritional information is available upon request. There's an option for establishments that have menus and menu boards targeted to children to provide information about children's calorie intake, and the nutrition information has to be available on site. The federal regulation has much more detailed requirements that are found in the health code for the calorie labels, position, size, and color. And here the health code has to track the federal regulations, so our proposed amendment does that. The calorie label has to be adjacent to the menu name, item name, or price. The type size can be no smaller than the name or the price, and the color has to be the same or at least as conspicuous. Similarly, the federal regulation has very detailed requirements for labeling variable menu items. We're proposing that we track that as we must. Those variable menu items are multiple serving items, combination meals, items with toppings, items that come in different flavors and sizes, beverages, and self-service items. And we have some examples so you can see sort of before and after. So this is an example of a multiple serving item, and you'll see on my left how that's posted under the current health code requirements. So this is an example of a medium cheese pizza. The calories have to be listed. Calories are 1,680 calories for that entire pizza. Under the federal regulation and our proposed health code amendment, the establishment has the option to post that calorie amount for the entire pizza, or to list per serving, per slice here, 210 calories a slice, so long as they also indicate how many slices in the whole. Here's an example of a combination meal with two variations. On the left, my left, is the health code posting currently. This is an offer of a sandwich. You can order either apples or chips with that. And calories are posted as a range, 590 to 660. And under the federal regulation, where there are two options, it has to be listed with each option and a slash in between. And where there are three or more options, then the establishment posts that as a range. And one last example, an item that can come with toppings. Again, you see the health code requirement. Here the menu item is a scoop of chocolate ice cream, which you can order with toppings. And the range is calories from 250 to 660. And under the federal regulation and under our proposed amendment, you have to list the calories for that item without toppings, and then list each topping with its calorie amount. And then finally, the federal regulation has a longer list of exceptions to calorie labeling, and again, the health code has to track this language. And the exceptions are places where calorie labels are not required. And this is temporary menu items in the current health code. That we define that to be an item on the menu for under 30 days, but the federal law says under 60 days. And the federal law also specifies custom orders, daily specials, items that are part of a customary market test, condiments, and items listed on a menu or a menu board that is not a primary rating. So with those changes, the health code would be brought into alignment with the federal regulation, allowing ongoing enforcement. We're also proposing that the board set the effective date at December 1st, so that we are in line with the federal effective date. And I think with that, we can take questions.
Presentation's now open for questions. Dr. Richardson and Dr. Quigley.
Yes, so thank you for that presentation, and it was fun to review the history of doing the calorie counts and being sued and redoing it and being sued again, and then ultimately prevailing, and then also seeing it really be disseminated across the country and now finally to be enacted federally. So I think it's a real success story for public health. One of the things that I noticed, and I just wonder if the department has any data on this, is that in addition to that, once the calorie counts were posted, and we could all see that, you know, oh my goodness, that muffin was 850 calories. It seemed to me that many food service establishments started offering healthier, lower calorie items on their menu boards. Is there any data to support this observation? It seemed to me it was a very pleasing, though unintended consequence. Again, we just wanted to let people have the information to make the choice. But I think we may actually have pushed the restaurant industry into offering healthier choices simply by making the calories available. Is that true?
There have been a couple of small studies looking at specific restaurants and the change in the menu items offered over time. And I think your observation is absolutely correct and consistent with what we saw. Not only did sometimes the products change, but the portion sizes also sometimes changed, resulting in lower calories and better options for consumers as well.
Yes, I think some of the outlets had sort of sticker shock at the calorie counts. They themselves hadn't really realized until they had to post them how high their calorie counts were. Dr. Klitzman.
Yeah, thank you both, and I also second Dr. Richardson's comments, and also I was delighted to see that almost 80% of people appreciate the menu labeling. When this initiative first started, we were anticipating, well, we didn't really know what to expect, and when people understand it and when they find it useful. So that's really a wonderful testament to the department's success in this area. I just had a few questions just so I can understand the difference. I mean, to me, in reading both the department's regulations and the federal standards, to me they're substantially the same. I don't see major substantive differences, but I just had a few questions. first of all, is there an impact on the different requirements in terms of numbers of establishments? Are there many requirements in New York City where there are only 15 to 19 national chains?
So we looked at that and tried to figure that out. It's frankly a number that's hard for us to get a handle on, because when we ask the question, the issue for us is meeting that threshold of 15. So we think it's a not insignificant number, but we can't tell you exactly what that is.
Okay, thanks. And also, can you just clarify how mobile food vending carts are treated under these regulations?
As in the current rule, mobile food vending carts are treated in the same way. So there are some mobile food vending carts that are part of a national chain, and they post calories.
Okay, great. And there was also something in here about having to post menu calories on menus that are on the internet. And I just wondered about that provision. How is it tracked? Do inspectors look on the internet? Because nowadays, just about, all restaurants, you can go on the internet and look at the menu.
So I think we'll need to take a look at that and develop protocols for how to evaluate those menus.
And then my last
We should
question.
point out, that's part of the federal requirement, the federal definition, the primary menus include the internet, so it'll be a federal violation of the internet.
Yeah, so at some point, when you have experience with this, it would be helpful for you to report back to us on that provision. And then my last question is about the signs. So it sounds like the format of the signs, there's going to be a requirement that it change for many establishments, although in practice, the information is largely similar. Whether you have a range of calories versus listing the increment for your peanuts and hot fudge and whatever else you're going to put on your frozen yogurt. But in essence, the information is substantially the same previously and in the future. And I just wondered what the department's thoughts were about, from an enforcement standpoint, how you're going to work with food service establishments to achieve compliance of the change in format.
Well, whenever the board promulgates a new rule, we work hard to educate the industry about compliance. We notify them when the rule is up for public comment, and we seek their feedback, and then if it becomes effective, we then do in a variety of different ways we educate them. I think this education will be happening nationally and also locally.
So if this is enacted on December 1st, 2015, and in the beginning of 2016, there are inspections conducted, will establishments have a certain period of time to comply with the new format of the signs? Will they be expected to comply right away? Is that something to be worked out?
I don't think a decision's been made on that yet. I mean, we'll have to hear the public comments and what we hear. I mean, I think we did do that the last go around. The FDA is going to be putting out guidance. This is a national issue, and we'll be hearing about how hard it will be for the big chains to comply with it, but it's something no decision's been made on.
Okay, thank you.
We also know that they are, because as Tom said, they are working on this already.
Thanks.
The overarching goal of this request to repeal and reenact is to bring us into alignment with the federal rules which go into effect on December 1st. And how their rulemaking isn't really finished yet. We don't know how they're going to ask it to be implemented. I think.
The rulemaking is finished.
Yes.
There may be some guidance coming out.
Right, I'm sorry, I've misspoken. The guidance on the rulemaking is still in process, but nationally, we need to act so that our health code remains in alignment. There are some ways in which we're going beyond the federal rule in a way that we are permitted to. That includes adding the 15 to 19 chains, the size of the chains will include the 15 to 19 as they've been for years now. This has been implemented in New York since 2008, including the mobile vending. And I hope it's really clear to the board that this will now include restaurant-like food that's sold in chains that we don't inspect, including convenience stores like 7-Elevens, and also in supermarkets that sell restaurant-type food. There will now be calorie information. So just to echo what everyone else has said, I think this is a real tribute to the board and its prescience and enacting the calorie posting rule now nearly a decade ago, and an example of how the city can really guide the nation.
Yes, I didn't.
See you there, Squire, please.
Oh, I'd like to call the question, I think.
Oh, you want to call the question? I thought you said you had. Yes, I think that there are no further comments. May I have a motion to approve? All in favor? Are there anyone opposed? No. No, it was unanimous.
Nicely done.
Thank you to the team. We now move on to the next item, which is the proposed resolution to add a new section 8149 to Article 81, food preparation and food establishments. I think Dr. Angel, you'll remain with us, and please introduce yourself again for the record.
Sure, I'm Dr. Sonia Angel, Deputy Commissioner overseeing the Division of Prevention and Primary Care.
And Christine Johnson Curtis, I'm the Assistant Commissioner for the Bureau of Chronic Disease Prevention and Tobacco Control.
Great, so thank you again for this opportunity to introduce yet another crucial amendment to support the health of New Yorkers. As mentioned, my name is Sonia Angel, I'm the Deputy Commissioner, and I'm here with Christine Johnson, Assistant Commissioner. Today we are proposing an amendment to add a new section to Article 81 of the Health Code to introduce sodium warning labels in food service establishments. So as you know, heart disease is the leading killer nationally as well as here in New York City. Nationally, 1 in 3 adults has high blood pressure, also known as hypertension, which contributes to approximately 1,000 deaths a day. Here in New York City, 1 in 3 deaths is due to heart disease. Staggering disparities in morbidity and mortality exist. 36% of Black adults have been told by health professionals that they have high blood pressure, which is nearly 50% higher than whites. And premature death, defined as death before year 65 years old, from heart disease is more than 80% higher in Blacks than in whites. High dietary sodium is an important contributor to heart disease and stroke. Decades worth of scientific evidence shows that excess sodium intake is dangerous. It can lead to high blood pressure, interferes with proper blood pressure control, and increases the risk of heart disease and stroke. Warnings about the sources of excess sodium can help New Yorkers. There's little public awareness about sodium intake recommendations and the major sources of dietary sodium. Because of this, most New Yorkers eat too much sodium. More than 80% of adult New Yorkers consume more sodium daily than is recommended for the entire day. Disparities also in consumption are also reflected in the health disparities that I've described before. Black New Yorkers consume more sodium daily than white New Yorkers. Nationally, too few consumers understand that high sodium intake is a serious health hazard, and there's only limited awareness of the link between sodium, heart disease, and stroke. Consumers lack information about the risks related to excess sodium intake. Many would never imagine that there are menu options in restaurants today that contain more sodium than a person should consume in an entire day. In addition, the variability of sodium content between similar products based on formulation makes it difficult for consumers to make reliably healthy choices. Even items that sound healthy, like a salad entree or a turkey sandwich, can contain more sodium than the daily recommended limit, undermining consumers' efforts to heed health professionals' advice to avoid excess sodium. This chart shows 2 menu items currently offered at a restaurant chain doing business in New York City. The sodium content of the smokehouse turkey panini is nearly 3 times as high as the sodium content of the roasted turkey and BLT sandwich. A consumer might mistakenly believe that both of these are relatively healthy options containing similar amounts of sodium. Today, we're proposing an amendment to Article 81 of the Health Code that is designed to address this issue. The sodium warning label regulation would require that items containing 2,300 or more milligrams of sodium be identified on menus and menu boards with the warning label icon displayed here. Language defining the warning label would appear at the point of purchase and read, "Warning," and show the symbol, indicates that the sodium salt content of this item is higher than the total daily recommended limit, 2,300 milligrams. High sodium intake can increase blood pressure and the risk of heart disease and stroke. This regulation would affect chain food service establishments with at least 15 locations nationwide, a universe that accounts for approximately 1/3 of restaurant traffic in New York City. So it's important to outline our rationale for key elements of this proposal. First of all, why restaurants? So people are consuming more and more of their food away from home. Processed and restaurant foods makes up the majority of dietary sodium intake, and evidence shows that restaurant food is more sodium dense than food prepared at home. As you can see from this chart, naturally occurring sodium and sodium added at the table and during cooking, which is primarily added as salt, represents a small fraction of the overall dietary sodium intake. And why restaurants? Well, in 2014, from data from MenuStat, a national database of thousands of foods served by the nation's largest restaurant chains, demonstrates that very high sodium items are currently offered in chain food service establishments in New York City. This graph illustrates the results of an analysis of more than 8,500 menu items offered in more than 50 local chain restaurants. It shows that roughly 10% of menu items across a variety of restaurant types contain at least 2,300 milligrams of sodium, the daily recommended limit. So why warning labels? Well, there's evidence that health warnings can increase knowledge and decrease the purchase and consumption of certain products. Most importantly, warning labels facilitate education. They can inform customers of the risks of consuming certain products. Additionally, more than 1 million New Yorkers see calorie labels daily in New York City restaurants, and a vast majority of them find calorie labels useful, as mentioned prior. So why 2,300 milligram limit? Leading scientific bodies, including the Institute of Medicine, the U.S. Department of Health and Human Services, and the USDA, recommend that no one's daily limit should exceed 2,300 milligrams. Excuse me. The proposed regulation is designed to identify items that contain more sodium than a person should consume in an entire day. These items are incompatible with recommended daily sodium limits, and the icon warns consumers about the health risks. Adopting the sodium warning label requirement is a sanctioned action of this Board of Health. Federal labeling laws allow localities to require warnings about dangerous food. Additionally, the New York State Court of Appeals recently recognized that warnings and instructions are valid exercises of this board's authority. We anticipate that this regulation will pose a minimal compliance burden for the impacted restaurants. Chain food service establishments will already be required to maintain information on the sodium content of menu items per the federal calorie labeling requirement that we just discussed, to provide complete nutrition information upon request. In addition, menu items in these restaurants are typically standardized, which also facilitates compliance. The regulation would go into effect December 1st, 2015, to coincide with other menu and menu board changes required by calorie labeling amendments. Inspections for guidance and compliance would be incorporated into the regular inspection process, and violations would incur a $200 fine, but would not impact a restaurant's letter grade or the frequency of inspections going forward. To summarize, this amendment would require sodium warning labels on menus and menu boards identifying items with at least 2,300 milligrams of sodium, the daily recommended limit. The warning label would be accompanied by language explaining both the meaning of the label and sodium intake recommendations that would be required by chain restaurants in New York City with at least 15 locations nationwide. Thank you for your time and consideration, and I'm happy to address any questions that you may have.
Thank you. The presentation is open for discussion. Dr. Gallo.
I just want to make a comment. I want to thank you for that very clear presentation. What's evident in your presentation, as well as in my practice as an internist, is that hypertension is a major risk factor for stroke and heart disease. We know that with my own clinical practice, so many of my patients have ended up with strokes and heart attacks and resulted in disability at young ages, and with disability in situations that could have been prevented. We also know that sodium intake elevates your blood pressure, and that's a risk factor for heart disease. And we also know there's good evidence that reducing salt intake reduces blood pressure. And I think we're at a place in public health now where we're really giving consumers information. And it's a really important phase that we're seeing where we're empowering consumers. But at the same time, information itself is sometimes not enough. We have to give information in a way that is accessible and is understandable for the public. And I think that this proposal moves us in that direction. And this is not about losing choice for consumers or for restaurants. I think this proposal really is about empowering consumers to be able to receive nutritional information in a way that is both accessible as well as understandable so that they can make better decisions about their food choices. So I just want to applaud you on this proposal. I think if we move forward with this, I think this is a real win for public health as well as for consumer rights and for New York City. Thank you.
Thank you, Dr. Gill. Did you want to say something, Dr. Gill? No, Dr. Richardson?
Yes, I also would like to thank you for your clear presentation and for your work on this. And I like the idea of the icon as opposed to adding more text to labeling boards. But I just wonder if you could talk a little bit more about your decision to use the the maximum daily recommended amount as the threshold. I could certainly see that if this moves forward and I see this little icon, that now I have something that I don't want to order clearly laid out, but you're not giving me any information on the items that don't have an icon as to whether they have 2,250 milligrams of sodium or 500 milligrams of sodium. And so I just wonder if you could talk a little bit about why you took this approach. Did you consider either a lower limit for the icon, because that's like it for the day, right, if you eat that one item, but I might eat 2 other items which actually total more than the recommended limit for the day because I don't have any information on how much sodium is in those. So could you just talk a little bit about why you decided on this approach, and did you consider alternatives?
It's an excellent question, thank you. One of the challenges is to identify at what level you want to give consumers information, and that information would be valuable to most, if not all, consumers that come into the restaurant. It is absolutely irrefutable that 2,300 milligrams or above at one sitting is absolutely not compatible with anybody maintaining the recommended limit. So there was no question that that level was one of concern. We then looked very closely at MenuStat and other data resources that we had to understand how many products actually contain more than 2,300 milligrams. I think we were all a bit surprised to realize that 10% of items in an estimated amount would actually end up with these labels on there, and we felt like that was an important level to set it out for consumers to understand this. I think your second question about what about all of the other products, how can people get that information? That's also a very important question. Our goal here was not only to identify high sodium products, but to link it with that knowledge of why it's important to act, that's why it's a warning label. Also concurrent with this, as presented before it, the calorie labeling requirements will also be going into effect at the same time, and they will require all restaurants to have information available to consumers at the point of purchase upon request, information about sodium. So those consumers who do want that information, it will be accessible to them.
If I could just have a follow-up, so I'm trying to imagine being online at a fast food restaurant, and before I select my sandwich, I would like them to tell me how much sodium is in each version of the items on their menu board. It being available on request, I don't think is a very effective alternative. I'd like to make a suggestion. Might it not be possible to have perhaps 2 icons, one at the daily limit and one at 50% of the daily limit, so maybe a yellow and a red, so that at least I can now pursue making choices that are not only don't blow the sodium limit for the whole day, but are amongst the lower sodium items on the menu. Maybe give me just a little bit more information with the icon approach. I just wondered if that had been considered.
Again, I think it's a question of how much information you're putting on the menu board. And I think what you're illustrating is it's a complicated environment when people walk in to either see a menu board above or look at a menu board to be able to get information in a way that allows them to quickly process it and use it for decision making at that time. But I thank you for the proposed iteration, and we can certainly consider it as we look forward.
I would just add, Dr. Richardson, that the requirement that the information be available upon request is a federal requirement that we're tracking. We could not, we can't do labeling, we can't require us to put sodium content on the board because it would be inconsistent with federal law. We do have authority to do a warning, and we picked this because these items are clearly beyond the daily recommended lines.
Maybe a couple levels of one?
We'll consider it.
I think that that's the sort of thing that will come up in a public comment period. I have Pam Breyer, she had the question.
Same question.
You did, okay. Well, some of you may remember who were on the board that initially there was this kind of question came up of why not put more information when we talked about calorie posting, and at the time we decided that that was probably the single most important piece of information, and that is the issue of clutter of the board. People who eat too much salt have a lot of company. 40% of adults eat above the recommended amount, so this is a way to start to help people identify things that really have an indisputably excessive level of sodium. And of course, we'll get ideas from the public comment period if the board agrees that this should go forward. Are we ready to call question on this?
Yes, we are.
All right. Motion to approve for publication.
Second.
May I have all in favor?
Aye.
Any opposed? No abstentions, the motion passes unanimously. I thank you for an elegant presentation, and we now are going to give an update to the board on a rule that was passed previously on an issue that we worked with our Health Committee Chair, Corey Johnson, and the City Council. And we thought it would be useful to you to see some information that we have that are at the 6-month mark almost of making changes in the requirements for changing gender for people on the birth certificate. We have a presentation, and when you get it up, can you introduce yourself for the record?
Absolutely. Hi, my name is Gretchen Van Wy. I'm the Assistant Commissioner for the Bureau of Vital Statistics here at the New York City Department of Health and Mental Hygiene. I'm happy to be here today to update you on our progress in implementing our new process to change the gender marker on New York City birth certificates. So just as background, the New York City Department of Health and Mental Hygiene is responsible for registering all the births that occur in New York City. We're one of 57 independent jurisdictions in the United States that does this. Birth certificates are scientific, legal, and foundational documents upon which all other official identity documents are based, including U.S. passports, driver's licenses, and social security cards. They are proof of U.S. citizenship and may be amended only upon presentation and acceptance of proper evidence, and this evidence is critical to maintaining the integrity of the National Vital Event Registration System, which is really an interconnected web of mutual reliance. As an independent vital records jurisdiction, we work in close partnership with the federal government, New York State, and the 55 other vital event registration systems in the U.S. to ensure the accurate representation of the facts of birth. So together across the U.S., we register nearly 4 million births each year, and we maintain the birth records for all of these individuals throughout their lives and after their deaths. Clearly, without birth record integrity, passports, driver's licenses, and other core identity documents would be questionable here in the United States. not only for us here, but also other jurisdictions and organizations around the world. On December 9th, 2014, the Board of Health voted to amend the process to change the gender marker on the New York City birth certificate based on a proposal made at the October Board of Health meeting. City Council passed a similar policy at this time also, which would modify the administrative code. So the updates were that we eliminated the surgery and name change requirements that had been previously recommended or required, and we replaced them with an affirmation or affidavit from a US licensed health or mental health provider. And on January 12, 2015, the regulation change was implemented. So next, I'd like to tell you a little bit about our implementation process. So after proposing the change to the Board of Health in October 2014, the Bureau of Vital Statistics staff formed a planning team to prepare for the implementation of the regulation change should it be approved. The team consisted of the 6 Bureau members who were really responsible for the administration and management of the birth certificate amendment process. We process about 50,000 corrections and amendments each year, and we had processed about 20 gender marker change birth certificates each year in the past years, but we are anticipating an increase in the number of applications given the change of the rule. The implementation components included an internal operationalization that included developing tools, procedures, and training for our staff in the Bureau so that they could act on the rule change and be prepared to help registrants, and then also conducting direct outreach to applicants. So we sent letters to then current applicants whose applications would be approved under the new rule, but not the old one. And we also contacted registrants whose applications had been rejected in the past several years, so we could let them know that the regulation was changing. We also created a direct email account to the team who processes these applications, so people could contact them directly rather than the general Vital Records group. And new customer instructions were developed and included in a toolkit for walk-in customers and also posted online. Included in the toolkit and our materials online is this template provider attestation document, which was designed to make it as easy as possible for applicants and providers to submit all of the information necessary to achieve a speedy approval of their gender marker change application. This was really just done to make things easy, and it wasn't a requirement. We also made changes to the health department website and of course to the 311 script that is used for any time anybody calls 311 and asks about making a gender marker change on a birth certificate. And in tandem with these internal changes, we made some efforts towards external communication. We developed an outreach plan to ensure that everyone who should be aware of the change was not only aware, but also knew how to pursue the change. And this was important for us not only to reach people directly who are registrants from New York City, but also the people around the country who help those people. So we developed a list of about 300 trans providers, advocates, and community centers across the US, because once you're born in New York City, you tend to move anywhere you want. We've hosted monthly webinars on how to navigate the process, and we'll continue hosting these webinars on a quarterly basis going forward. Our colleagues in the Bureau of HIV have also developed a lay-friendly brochure being developed on trans women's health, and they soon will be releasing one on trans men's health. In those brochures, they mention how people can make the gender marker change on their New York City birth certificate. Also coming out soon, we have a transgender city health information document. And this is a document that is intended to educate medical providers on different health topics. And this one will be focused on providing primary care to transgender adults. In addition to these efforts, we're conducting an evaluation on the impact of the regulation change on the New York City-born transgender population. We're really interested in understanding how this document change allows people to have different experiences with regard to healthcare access, with stigma and discrimination, and how these experiences may change over time. We have IRB approval to do this for at least 5 years, but we're hoping this can go on in a very long term and as a longitudinal study. Applicants receive information about the survey in the same packet as their new birth certificate. It's not addressed, it's something that's entirely voluntary and people don't have to participate at all. So I wanted to share with you the exciting part, which is the data on this as well. So when we look at the numbers for transgender birth certificates in New York City, we've processed, as of last week, 149 new transgender birth certificates. So, you know, when we think that in past years we've processed about 20, that's nearly 8 times as many as we did in past years. So we're really delighted with how this is rolled out. Another interesting thing to note that's really important is that we have really similar proportions of male to female and female to male issuances. That's important because in the past, we had more male to female applicants be successful. Now we see that there's more equity in that. And we have about a 2.3-day turnaround time for these applications. So our next steps are really just to continue to process applications in a timely manner. We've also been accepted to present at the American Public Health Association Annual Conference in a special session on gender affirmation and health. And we'll be giving just talking a little bit about New York City as a case study for using vital records to advance health equity. And we'll be participating with scholars from Columbia, McGill, Harvard, and the Center for American Progress. We'll continue our evaluation of the regulation change. We'll continue to expand that outreach list, which is really growing, and we just keep on adding people to it. Our webinars will become quarterly starting in July, and that's only because we've had a little bit of a dwindling in the participation. And we'll continue to train our new staff in providing a trans-friendly workplace and just providing the services that we provide. So with that, I'd like to thank you for your time and open it up for questions.
Thank you, that's a very rewarding update. Any comments or questions?
Just very well done.
Well, thank you to the board.
And thank you for sharing that. I really think you're to be complimented on the efficiency with which you implemented this, and the 2.3-day turnaround time for issuance of any governmental official anything is truly amazing. So thank you very much.
Thank you.
Well, it's so interesting as a new board member to hear about some of the past work, and just curious about how often that happens when rules get changed or code gets changed, that you hear kind of the results of the change.
This is something that we've added to the board presentations. We think it's useful for you to understand, you know, what it takes, for one thing, to implement some of the rules that you approve, and what its impact is.
It's very helpful.
I'm glad you enjoyed it, and with that, I would, if there are hearing no further comments, I'd like to thank Dr. Benoit, and I have 11:25, and we declare this meeting adjourned. What was her name?